All right, so we're going to talk about hematologic malignancies. This is going to cover basically all your leukemias and your Hodgkin's lymphoma, stuff like that. So let's get started with Hodgkin's lymphoma. All subtypes of Hodgkin's lymphoma are more common in males except one. There's 5 subtypes: nodular sclerosing type, which affects young women greater than men. So you need to know that. The identification of Reed-Sternberg cells, which you can see right there, are required for the diagnosis of Hodgkin's lymphoma. Reed-Sternberg cells, now, they're classically seen as cells with 2 nuclei surrounded by a clear cytoplasm. Reed-Sternberg cells are of B cell origin and are CD15 and CD30 positive. Note that Reed-Sternberg-like cells are present in infectious mononucleosis as well as NHL, or non-Hodgkin's lymphoma. These cells must be distinguished to be true Reed-Sternberg cells. Hodgkin's lymphoma presents as an acute infection, so you're going to have diaphoresis, pruritus, leukocytosis, and localized non-tender lymphadenopathy. That's important. Also, B symptoms, so you're going to get fever, night sweats, weight loss. Now, lymphadenopathy is the most common above the diaphragm, 80% actually. So you're going to see it in the cervical, supraclavicular, and axillary regions. On imaging, a mediastinal mass, or which is known as mediastinal lymphadenopathy, is a common finding. Hodgkin's lymphoma has a bimodal age distribution. The prognosis negatively correlates with the number of Reed-Sternberg cells, but positively correlates with the number of reactive lymphocytes. So basically what that means is more Reed-Sternberg cells, the worse prognosis. The more lymphocytes, the better the prognosis. All right, so let's talk about the 5 subtypes. Nodular sclerosing. Nodular sclerosing, you're going to see 65 to 70% of cases. On biopsy, affected lymph nodes have fibrous bands and lacunar cells, which are Reed-Sternberg cell variants. So fibrous bands and lacunar cells. So the fewer the Reed-Sternberg cells, you have a lot of lymphocytes, so you're going to have an excellent prognosis. Now let's talk about mixed cellularity. This is 20 to 25% of cases. It's strongly associated with EBV. Strongly associated. So you're going to find this in older patients. Characteristics are polymorphic infiltrates like eosinophils, plasma cells, lymphocytes, Reed-Sternberg cells. Lots of Reed-Sternberg cells, and a moderate number of lymphocytes is an intermediate prognosis. Then we're moving on to lymphocyte rich. This is an uncommon form of classical Hodgkin's lymphoma. It's associated with the EBV infection in approximately 40% of cases, and you have a good prognosis with lymphocyte rich. They're not going to test you on that one. Lymphocyte depleted, this is the least common form, less than 5% of cases. So the 2 that I would not worry about is the lymphocyte rich and the lymphocyte depleted. This is going to be an older age, and it's associated with HIV status. Lots of Reed-Sternberg cells and few lymphocytes, hence lymphocyte depleted. This has got the poorest prognosis, so you might need to know that. This is the poorest prognosis. Because remember, the more lymphocytes you have, the better your prognosis will be. So let's talk about lymphocyte predominant. This is a non-classical Hodgkin's lymphoma that accounts for approximately 5% of cases. The only subtype of Hodgkin's lymphoma to have non-classical appearing Reed-Sternberg cells. All right. So this has few Reed-Sternberg cells, lots of lymphocytes, hence lymphocyte predominant. You have an excellent prognosis with this. Note that unlike the other subtypes of Hodgkin's lymphoma, the cell surface markers of lymphocyte predominance are different. You're going to have CD20 positive, CD15, CD30, and EBV negative. So this one is CD20 positive, CD15 negative, CD30 negative, and EBV negative. And that is Hodgkin's lymphoma in a nutshell for you, or what you need to know. So let's talk about leukemias. Leukemic cells often infiltrate the marrow, disrupting normal hematopoiesis. So you're going to get a leukopenia, which is going to increase your infection risk. You're going to get an anemia. And you're going to get a thrombocytopenia. So you're going to get hemorrhagic complications with the thrombocytopenia. Now, you got two types of leukemias. Well, actually, that and subdivisions of those. You got acute and chronic. Now, acute leukemia is some clinical findings generally abrupt. It's abrupt in onset. You're going to have fever, bleeding, and fatigue that are commonly found. The laboratory findings of acute leukemias include thrombocytopenia, hypercellular bone marrow with greater than 20% blast. It's usually an elevated white blood cell count. You have a bimodal distribution, so children and greater than 60 years of age is what that means. Without intervention, acute leukemias are often fatal within 6 to 12 months. So what about chronic leukemias? Some general facts is it's insidious in onset when compared to acute leukemias. It's characterized by generalized painless lymphadenopathy. The laboratory findings are similar to acute leukemias except for the blasts, which are less than 10% in chronic leukemias. What were they in acute? Greater than 20%. That's your clue. The clinical course is less devastating, but also less responsive to therapy. So now let's talk about the acute leukemias, acute lymphoblastic leukemia. This is the most common malignancy in children. It's also the most responsive to therapy. There are two types, two general types. You got B, acute lymphoblastic leukemia, and you got T, acute lymphoblastic leukemia. Now, B, acute lymphoblastic leukemia, presents as a blood disorder, which will generally metastasize to the CNS. The surface markers are CD10, which is also known as CALA. You will see that. CALA, CD, and it's a B cell thing, so you're going to have a B cell markers, CD19, CD20, and CD22. The translocation that is commonly asked is in the B cell, or the BALL is a T translocation 1221. Now, the TALL presents commonly as an anterior mediastinal mass. The surface markers for it are different. It's CD1, 2, 3, 4, and 7. Now, CD10 is a specific B cell marker, so it's not present. TDT is a marker for lymphoblasts, thus is found in both BALL and TALL, but is not specific to either. Now, Lymphoblasts predominate. The following features portend a poor prognosis. Age less than 2 or greater than 12, you have a poor prognosis with ALL. Peripheral blast count greater than 1,000, you have a poor prognosis. In the presence of a 922 translocation, which is the Philadelphia chromosome, you also have a poor prognosis. So now that takes us into acute myelogenous leukemia. So acute myelogenous leukemia or myeloblastic leukemia, this commonly occurs in young to old adults, early 20s to early 60s. The most important one to know is APML, acute promyelocytic leukemia. Now, the translocation 1517 creates a fusion protein with the retinoic acid receptor and the promyelocytic protein. So the peripheral smear is characterized by eye rods. And then remember that was a T1517 translocation. DIC is a common complication. That's going to be tested. So the presence of a translocation of the 1517 is important therapeutically because it can be treated with high doses of all-trans retinoic acid, which is vitamin A, which binds to the PML RAR protein and acts as an antagonist. So it accelerates differentiation of promyelocytes into what? Neutrophils. Now these eye rods, those are needle-shaped azrophilic material found only in AML, either myeloblastic or monoblastic. Leukemic therapy can release eye rods. So that's why you can get DIC with leukemic therapy for AML. And that takes us on to CLL, chronic lymphocytic leukemia. This is the most common leukemia found in adults in the U.S. Patients usually are male, greater than 60 years of age, and experience an indolent clinical course, generally presenting asymptomatically with leukocytosis. Otherwise, they can present with fatigue or generalized painless lymphadenopathy. The mean survival is 3 to 7 years. An infiltration of marrow, spleen, and liver, so you're going to see hepatosplenomegaly. The white blood cell range is 50,000 to 200,000 cells per millimeter cubed. Now, the cells express B cell markers, so CD5, CD23, CD19, and CD20. Chromosomal translocations are very rare in CLL. That is important. What you look for is something called smudge cells. On the smear, these occur as the leukemic cells are prone to mechanical disruption. There's an increased incidence of warm IgG-mediated hemolytic anemia. Malignant transformation of B cells leads to a decreased production of plasma cells, so you get a hypogammaglobulinemia. So what's that mean? You're at increased risk for bacterial infections. And that is CLL for you. So now let's talk about CML, chronic myelocytic leukemia. The peak incidence in middle age is 35 to 50 years of age. These have a myeloid stem cell predominate. The Philadelphia chromosome, the 922 translocation, creating the BCR-ABL fusion gene with tyrosine kinase activity. All right, so the white blood cell range can range from 50,000 to 200,000. Leukemic leukocytes have a very low leukocyte alkaline phosphatase activity compared to a leukomoid reaction. Most cases result in blast crisis. The number of blast forms increase and behaves like AML, short survival and rapid progression. And how do you treat CML? You can treat this with imatinib or Gleevec. All right. So what about hairy cell leukemia? This is a chronic B-cell leukemia, which usually affects middle-aged men. The average age is around 55. Leukemic cells infiltrate the bone marrow, liver, and spleen, so you're going to see splenomegaly is more common than hepatomegaly. You're going to get a pancytopenia that results, so you're going to get an increased incidence of infections. Now, here's the part you got to remember. Cells stain positively for TRAC, tartrate resistance acid phosphatase. It responds well to therapy, and the first line treatment for hairy cell leukemia is 2-chlorodeoxyadenosine. All right, and that takes us on to a board favorite, multiple myeloma. Multiple myeloma is a plasma cell neoplasm which is characterized by diffuse involvement of the skeleton. Because multiple myeloma originates in the bone marrow, it is essentially a leukemia. However, unlike other leukemias, myeloma cells are B cells that have undergone somatic hypermutation to become plasma cells. Malignant cells readily seen on bone marrow biopsy or aspiration, which is required for a diagnosis. Multiple myeloma is generally considered a disease of the elderly with a peak incidence occurring between the ages of 65 and 70. Common features are hypercalcemia, so you're less likely to depolarize, renal insufficiency, anemia, Binge-Jones proteins, that's a big one, remember that. Bone lytic lesions, and infections. Because immunoglobulin production is compromised, the most common cause of death is recurrent infections. Um, you see Binge-Jones proteinuria in the urine, which is the Ig light chains. This causes renal insufficiency and is the second most common cause of death. The peripheral smear, which you will see on that, is the Rouleaux formation right here. See how these are lined up in like what looks like a Rolex? It's a stacking of RBCs, which is a sign of inflammation. Amyloidosis, the AL type, often occurs because of the excessive production of light chains. Tumors are what produce the lytic lesions of bone, causing severe bone pain and spontaneous fractures. The skull and the axial skeleton are what is most commonly involved. and it's the excessive bone resorption that can precipitate hypercalcemia. So, stones, bones, moans and groans, psychiatric overtones, blah, blah, blah. Since a plasma cell can only produce one antibody and is the clonal population, a massive quantities of one immunoglobulin called the M protein Note, this is not the same M protein associated with strep pyogenes. It's a single sharp spike on electrophoresis. It's usually IgG or IgA. Normal antibody synthesis can be impaired, so you're going to get infections. Like an example of that would be Haemophilus or pneumococcus. And that takes us on to MGUS. Monoclonal gammopathy of undetermined significance. This is 5 to 10% of healthy older persons. You're going to get a monoclonal M spike without Benz-Jones proteinuria. All right. You're going to be asymptomatic, and it's usually benign. The number of decreased concentrations of normal immunoglobulins. And now we're going to talk about Waldenstrom's macroglobulinemia. This is neoplastic B cells in lymphoblastic lymphoma produces a monoclonal IgM. There are no bony lesions in Waldenstrom's. Waldenstrom's macroglobulinemia is most commonly characterized by a hyperviscosity syndrome. So yes, you're going to see PEs in these people. You're going to see DVTs. You're going to see clots. Number one, you're going to have neurological symptoms. You're going to have visual impairment, headaches, deafness, lethargy. You're going to get cryoglobulinemia, which is a precipitation of macroglobulins at low temperature. So it may require plasmapheresis. And then you're going to see bleeding because the consumption of clotting factors into large complexes with macroglobulins can interfere with the coagulation cascade. Approximately 10% of patients have autoimmune hemolytic anemia caused by IgM, which is the cold agglutinins. So now let's talk about myelodysplastic syndromes. Myelodysplastic syndromes, or MDS, is a group of acquired dysplastic clonal disorders of stem cells. Cytopenias due to ineffective hematopoiesis occur. It usually affects men older than 50. You're going to get a refractory anemia that can sometimes progress to chronic or acute leukemias. There's 4 classifications. You're going to get a refractory anemia with ring sideroblast. You could see chronic myelomonocytic leukemia with myeloblast, or you could see a refractory anemia with excess blast and transformation. A severe pancytopenia with myeloblast on bone marrow aspirate is going to exist. Now, the thing I want you to remember about this is it frequently progresses to AML, acute myelogenous leukemia, which is going to be more than 20% myeloblast, going to have a disease progressing to AML. It's that simple. So myelofibrosis and myeloid metaplasia. This is a clonal myeloproliferative disease due to mutations on the JAK2 gene of chromosome 9. It's the same mutation that causes polycythemia rubra vera and essential thrombocytopenia. Its ineffective hematopoiesis and reactive myelofibrosis causes an extramedullary hematopoiesis. The most common cause of splenomegaly in patients over 50 is myelofibrosis and myeloid metaplasia. You're going to get a massive splenomegaly, so you're going to see portal hypertension. Splenic infarcts and left side of pleural effusions are also common. Bone marrow aspirate demonstrates fibrosis. Now, the peripheral blood smear demonstrates a leukoerythroblastosis. So the white blood cell count is going to be between 10,000 and 50,000. You want to see a normocytic anemia with dacrocytes. You're going to get a variable platelet count with an abnormal platelet morphology, and you're going to get normal to increased leukocyte alkaline phosphatase. The bone marrow fibrosis occurs early than in other chronic myeloproliferative diseases. So how do you treat this? There's two ways: hydroxyurea and alpha interferon. All right. And that takes us into non-Hodgkin's lymphoma or Burkitt's lymphoma. Burkitt's lymphoma, or small non-cleaved non-Hodgkin's lymphoma, is a B-cell lymphoma. It's linked to EBV infection. There's an African form and an American form. In the African form, the maxilla and the mandible are involved. In the American form, you're going to have abdominal organ involvement. You're going to see an 8-14 translocation. Which produces a c-Myc proto-oncogene moved next to an Ig heavy chain, which is causing a c-Myc overexpression. And that causes increased cell proliferation at a high grade. It can also be caused by a T translocation 2A or an 822. Notice 8's involved in all three of those translocations. You're going to get a starry sky appearance. Which is normal macrophages ingest cellular debris from rapid cell turnover. Because Burkitt's lymphoma exhibits a very high mitotic rate and rapid turnover of cells without high levels of apoptosis, it inherently cannot express the BCL2. Contrast with this, follicular lymphoma, where the translocation causes overexpression of BCL2. And that's what we're going to talk about right now. This is also a B-cell lymphoma and is the second most common non-Hodgkin's lymphoma. It classically presents in adults with a waxing and waning lymphadenopathy. Predominantly, it is centrocytes, small cleave cells expressing CD10, CD19, and CD20. It also expresses BCL2 and BCL6. Follicular, you're going to have a translocation of 14 to 18. And this is a juxtaposition of the BCL2, which is an oncogene that inhibits apoptosis next to an IgH locus. What this does is it leads to an overexpression of the BCL2, so you're going to get decreased apoptosis. Lymph nodes are obliterated by characteristic neoplastic nodules. They're usually uniform, round, and isolated. These nodules are compromised of B cells recapitulating the germinal centers of lymphoid organs. Let's talk about mantle cell lymphoma. Mantle cell zone lymphoma is B cells from the mantle zone of lymphoid follicles. The morphology is similar to SLL or CLL. SLL is considered a phase of CLL. You're going to get a translocation of 1114. which is going to cause a cyclin D1 overexpression, or BCL1. Which is going to increase the cell cycle, so you're going to get a high-grade, terrible prognosis with an average survival of less than 3 years. The mantle cell non-Hodgkin's lymphoma versus chronic lymphocytic leukemia both express CD5, CD19, and CD20. However, mantle cell non-Hodgkin's lymphoma is CD23 negative versus CLL, which is CD23 positive. So this is CD23 negative versus CLL, which is CD23 positive. This is incurable. It's often aggressive, disseminated, and it affects older men. So let's talk about an overview of non-Hodgkin's lymphoma. It's a malignant neoplasm, often originating from lymph nodes and lymphoid tissue. You can have a B-cell lymphoma, which originates from B cells within the germinal follicle and include Burkitt's lymphoma, diffuse large B-cell lymphoma, follicular lymphoma, a myeloma, and small lymphocytic lymphoma, which is SLL. Or you can have a T-cell lymphoma, which is mycosis fungoides and Sézary syndrome. This is where you're going to have peri-aortic nodes often involved, and a non-continuous spread is observed. So you're going to see a B-cell lymphoma, and T-cell lymphoma. There are several infections and predisposing conditions associated with the pathogenesis of non-Hodgkin's lymphoma. For instance, talking about myeloma with bacterial infections of H. pylori. This is a low-grade lymphoma found in the gastric mucosa associated with lymphoid tissue, example malt. You also have viral infections that are associated with this. The human T-cell leukemia virus type 1 causes adult T-cell lymphoma. EBV causes Burkitt's lymphoma, CNS lymphoma, and HCV causes B-cell lymphoma. Hashimoto's thyroiditis predisposes you to thyroid lymphoma. Now, diffuse large cell lymphoma, or BL or DLBCL, is the most common non-Hodgkin's lymphoma. Remember that. Diffuse large cell lymphoma is the most common non-Hodgkin's lymphoma. 80% are B-cell in origin, the remaining 20% are T-cell in origin. The presentation typically presents as rapidly enlarging masses that can present anywhere in the body. It can be found in nodule or extranodular tissue. It's associated with an aggressive widespread dissemination, rapidly fatal if untreated, and it is CD19 and CD20 positive. So let's talk about small lymphocytic lymphoma. This is a B-cell lymphoma. It's related to CLL. The WHO classifies SLL as a phase of CLL. You're going to see this in older persons, and it's going to have an indolent course. A biopsy is going to show effacement of lymph node architecture. Because of the B-cell origin, it most commonly expresses CD5, normally a T-cell marker, and also CD23. Because these are B cells, they are also CD19 and CD20 positive. You're going to see a widespread nodular involvement, which is going to have the liver, the spleen, the bone marrow, and all that's going to be involved as well. So what about a T-cell lymphoma? This is a precursor T-cell lymphoblastic leukemia or lymphoma. It's formally lymphoblastic lymphoma, but the WHO now classifies it as a form of ALL, acute lymphoblastic leukemia. You want to see a thymic lymphocyte origin. Usually occurs in children. That is important. Remember that. It presents with a mediastinal mass. It's rapidly progression because it's a ALL variant. Now, mycosis fungoides and Sézary syndrome are neoplastic conditions of CD4 positive T helper cells. Mycosis fungoides presents as a cutaneous rash which spreads to lymphoid tissue, liver, and lungs. And Sézary syndrome occurs when CD4 positive T cells invade the blood, so you get a leukemia. The circulating cells are called Sézary cells. And that brings us to the last thing, Polycythemia rubra. You just want to see an absolute polycythemia without hypoxic stimulus, usually due to a mutation of the JAK2 gene on chromosome 9. You want to see a clonal expansion of the myeloid stem cell, the same mutation found in myelofibrosis, myeloid metaplasia, and essential thrombocytopenia. So you're going to see an increased production of RBCs, granulocytes, mast cells, and platelets. Symptoms due to hyperviscosity and vessel congestion. So you're going to see hepatosplenomegaly and engorgement with blood cells. You're going to see a burning pain in the hands due to microthrombi occlusion of vessels, also seen in essential thrombocytopenia. You're going to see a ruddy face due to vessel congestion. You're going to see thrombosis due to hyperviscosity. And it also has a CNS involvement due to the hyperviscosity. So you want to see a headache, blurred vision, retinal vein engorgement, vertigo, transient ischemic attack, stroke, etc., etc. You're going to see an increased histamine. So that's going to lead to peptic ulcers and itching after a bath. And you're also going to see gout due to increased cell turnover with release of nucleic acids. Now, the last thing we got to talk about is you're going to see a decreased EPO, erythropoietin, with an increased hematopoiesis. And the treatment is used to reduce red blood cell proliferation. So you're going to have chemotherapy, and you're going to have phlebotomy to reduce the hematocrit and prevent thrombosis. And you can also use aspirin to prevent the thrombosis. And that is polycythemia rubra for you. And that is all the leukemias and all the myelofibrosis and everything there. So if you just, there's much, much more to this, but I just went over the high yield stuff. So if you pay attention to that, you should be fine.